The Self-Care Learning and Discovery Series is back, and it's bigger and bolder than ever. This is the premier self-care event of the year, bringing together self-care enthusiasts of all backgrounds and disciplines from around the world. The World Health Organization defines self-care as the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of a healthcare provider. We also know that self-care means different things to different people. What does self-care mean to you? You'll have ample opportunity to reflect on this question during the Discovery Series, with more than 20 interactive virtual sessions organized by self-care experts worldwide. The Discovery Series will elevate cutting-edge research, programming, and advocacy insights across a wide variety of self-care topics, and we encourage you to attend as many sessions as possible, especially on topics that may be new to you. The Self-Care Learning and Discovery Series, a core activity of the Self-Care Trailblazer Group, is organized by the White Ribbon Alliance in partnership with co-sponsor organizations and esteemed steering committee members. We also want to thank all our session organizers and presenters who have voluntarily dedicated their time to curate this event with us. We are pleased to share that every session will offer live, simultaneous interpretation in French, Spanish, and English. To access the interpretation, simply navigate to your meeting controls located at the bottom of your screen. Click on the globe icon labeled Interpretation and select the language you'd like to hear. Joining from your phone, tap on the ellipses to find the interpretation feature and then select your language. Please note, you can switch languages at any time throughout the presentation. The session is now about to begin. Don't forget, whether you're working to influence policies or programs, advance universal health coverage, or improve your own self-care, we hope that you will take the learnings from today's discussion and apply it to your own work. To that end, we invite you to continue the conversation and take action with us by becoming a member of the Self-Care Trailblazer Group. So get curious, jump in, and share your ideas and insights with us. We look forward to advancing self-care together.
Awesome. Welcome everybody. Good morning, good afternoon, good evening. I'm so thrilled to have you all with us today. Thank you for joining. My name is Trinity Zan. I am an associate director at FHI 360 based in North Carolina. And I am just thrilled to have you all today at our Listen Up session. It is no doubt going to be exciting and thought-provoking. We want this to be an interactive and safe space to engage our wonderful speakers who represent multiple countries at different points in their journeys toward implementing self-care for family planning and reproductive health. I'm going to introduce them in a moment, but the idea here is really that there has been so much momentum around self-care broadly and self-care for reproductive health that we thought we might take a step back and just ask some of the really big questions. Why are we doing this? What's the value? How are we doing it? And what are some of the challenges? And ask those questions to speakers with a range of experiences doing so. So I'm thrilled to have you. Please go ahead and introduce yourself in the chat. And we're going to make this as interactive as possible. So you'll see some Zoom questions. And at the end of the session, we will be having time for you to ask questions directly to our speakers. So let me first introduce those speakers so you have a sense of who is in this room, so to speak. So again, I'm Trinity. I work at FHI 360, and in particular, I'm a deputy director on a USAID-funded implementation science project for family planning. It is called Research for Scalable Solutions. And we implement research and research to practice on a range of topics, including self-care. And we have some really interesting research results that I'll be just highlighting before we get into the rest of the session. I am joined today by 4 speakers, the first of which is Dr. Hadiza Kadri, who is the country representative and Research Officer at EVIDAF, based in Niger. She has a variety of responsibilities and oversees a number of projects in Niger. Among those, she has helped to put in place and facilitate a working group on equity and self-care in family planning in Niger. And she was also intimately involved in one of the studies that I'll be mentioning. So we welcome Hadiza. She's also formerly, in her past life, worked at the Ministry of Health in Niger, as well as other organizations. We are also welcoming today from Kenya, Dr. Edward Serem, who is the Director of the Division of Reproductive and Maternal Health at the Ministry of Health in Kenya. And as the name would imply, he's in charge of maternal health, adolescent and youth, sexual and reproductive health, and family planning. And among his responsibilities, he has also been supporting and overseeing and driving the self-care journey in Kenya. So he will have much to share. He is joined by Karen Ora, who is a reproductive health specialist, also working in the Division of Reproductive, Maternal, and Child Health at the Ministry of Health. She has technical experience in developing many different policies and guidelines and protocols, including leading on the development of the self-care guidelines in Kenya. So again, we're honored to have her with us. And finally, we have Dr. Charles Olaro, who is the Director of Curative Services at the Ministry of Health in Uganda. Of course, he also has much experience overseeing, supporting, coordinating implementation in both the public and private sectors. And as with our colleagues from Niger and Kenya, has been intimately involved in the self-care journey in Uganda and the development of their national guidelines and their subsequent implementation. So I'm thrilled to have such an esteemed panel with us today. So I'd like to set the stage by first telling you briefly about why we kind of wanted to put together this panel. As I mentioned, we have conducted research under the Research for Scalable Solutions project to really investigate what people think about self-care. What does the term mean to them? What would they like to be accessing for self-care, for family planning and reproductive health? And what are they currently doing in their behaviors that may demonstrate opportunities to support self-care? So we've done 2 different multi-country studies. And of course, I don't have time today to go into all of the details, but I did want to share some of the key takeaways because I think they provide a nice foundation for us to then build the conversation. But before I do that, as just a fun teaser, I wanted to ask you all to respond to our first poll question. So if we could please launch the very first poll question, I hope that you will see it popping up on your screen. But the question is, when you first heard the term self-care in the reproductive health space, did you know what it meant? And your options are yes or no. So please go ahead and answer that question and we'll see how much you all felt you knew about the term self-care when you first heard. All right. Let's see, I'm trying to see if I can see results. Perfect. So on the screen, I'm seeing about 70% of you all said, yes, you did know what that meant. And maybe a little less than a third of you said no. So that's nice background. Thank you for answering that question. I would like to now, I'm going to share my screen and hopefully I do this correctly. So give me 1 second. Let's share. And I'm going to switch. I'm going to do presentation. And I'm going to switch this, I think. Perfect. So why did I ask you all to answer that poll question? Well, in fact, that's what we were trying to do with a range of individuals in multiple countries. Again, I don't have time to go into all the details, but I will share some links in the chat where you can hear more about these results. We did a webinar last week. We also have some briefs that we can share. But essentially, we asked women, as well as men and providers, and in Niger, community leaders, what is self-care? What does that mean to you? And perhaps surprisingly or unsurprisingly, the concept of self-care for family planning was really difficult for people to answer. And when probed, essentially what they responded is that means having access to information and services to allow you to space births, which, if you think about it, is kind of a general definition of family planning. So that was an interesting takeaway, and this happened kind of across countries. People's definitions were not linked to specific methods, so they weren't necessarily thinking about what may be considered self-care methods, like self-injection. People named a range of methods because, again, they were thinking about the ability to space births as being self-care. What was important is that people really emphasized key to the concept of self-care was feeling empowered with knowledge to make the right decision about when and how to space pregnancies. We also, within this, looked at people's fertility awareness, and that was very moderate, which is also important because understanding fertility seems like an important starting point for self-care for family planning. So room for improvement. What was very interesting is that across the board, what we saw was that individuals very much want an opportunity to link with a health facility, a health provider, or the health system in some way to access contraceptive methods and to support continuation. So we often talk about self-care, of course, as a range, a continuum of accessing information and services with or without a provider. But what we saw is that across the board, people very much want some touch point with a provider or the health system. There were some shifts that we saw for resupply where people were a bit more comfortable looking to pharmacies or drug shops or community health workers to resupply methods. And the reasons why people wanted to have that touch point are similar to some reasons that we often hear in other research, that in fact, the health system, the health facility might be closer, it might be more affordable, and they perceive it to have higher quality services. What we also saw, though, is despite an interest in having a touch point, there was also interest among women and men in accessing information about fertility, about different methods, and about side effects through other channels, in particular, mobile technologies or digital technologies. So these represent some windows of opportunity for self-care. We may be able to meet some people's needs by offering information and services through these different channels. Also, different channels could include drug shops. And in some cases, some small percentage of people were interested in home delivery or accessing information and services at a market, or maybe even through a friend. However, given the importance that people placed on engaging with a provider, what seems clear is that any of those windows of opportunity or those alternate channels would really need to fulfill the needs of people that we see being met by providers. So again, a perceived high quality of service, perceived affordability, proximity, et cetera. So I'm going to stop sharing now. This was just a very quick highlight of, let me see. Did I stop? Sorry about that. Having a little technological difficulty there. I do not. There we go. Just a quick synopsis of some of the results that we saw. Again, because we're going to be asking our speakers today to talk a little bit more about how they reacted to those findings. But before we do that, I'd like to ask one more question to you through a poll. it's just a teaser. You probably won't know the answer unless you had participated in our webinar last week. But if you had to guess, this is the question. Which of these was not a top reason cited by women in Kenya, Niger, and Uganda as a benefit of engaging with a provider when starting or using a self-care method? So what did they not see as a benefit? And the options are learn about different methods, get a recommendation, or that it's discreet and confidential. So if you would please answer that. We'll see what you all think. We'll just take another moment. All right, let's see what the results are. Okay, so 15% of you thought that learning about different methods was not a reason, not a benefit. Getting a recommendation, 40%. Discreet and confidential, 45%. So that was really the answer. One of the reasons people definitely thought it was a benefit to engage with a provider, to learn about different methods and to get a recommendation, but not necessarily that it was discreet and confidential. So again, I'll be placing into the chat links to some resources if your interest is piqued and you'd like to learn more about these research results. But with that, I would now like to turn to our panel. We will begin our fireside chat, or maybe it's too hot where you are and you would like this to be a poolside chat. So the point is we want this to be kind of an intimate setting where we get to engage together and really take advantage of these experts who we have with us today. So I'm going to ask my panelists to please turn on their cameras if they can. And I'm going to ask one question to each of the panelists. And I think also, please, just a reminder to make sure that you stay on mute unless you're speaking. So the first question that I'm going to ask to each of our panelists today is, given the results that I just shared, and which they know more intimately as they were involved in one way or another, how do you react to these results? What did these results mean to you? Did they or do they change or influence how you're thinking about self-care? And I'd like to first turn it over to Dr. Olaro, if you don't mind going first. Can you please just share a little bit briefly? We're looking at maybe 3 minutes apiece for you all. What did you take away from these results, or how did it influence your thinking in the self-care journey in Uganda? Over to you. Oh, Dr. Olaro, you're muted, so if you don't mind unmuting.
Sorry. Thank you, first of all, Trinity, for invitation, and also to all my fellow panelists and all those on call. The takeaway from this message definitely came at a time when Uganda already was developing its guidelines. So, but it helped us to do some aspect of fine-tuning, refining, and partially leveraging on the digital platform for self-care awareness and enhancing literacy, because part of awareness is really literacy. If people understand, then they will be able to do it. So for awareness creation, most of the people rely on health providers because that's how the system initially was designed. So people were not supposed to get the information elsewhere apart from the health workers regarding information on family planning. However, we also noted that people want to receive information from different platforms, like about products, sources, services, which probably could come from digital platforms. Like now, many people have phones, probably SMS, send a short message, SMS, social media, WhatsApp. So we found that this was quite good for us to be able to update to see that we can use the digital options to be able to complement the information which the people receive from health workers. Because the health providers alone caters for those who visit facilities. But if now a person doesn't go to the facility, then you're not able to access this information. The other aspect which it helped us to refine was aspect of initiation, which we think that initiation should, in the first instance, be through a trained family planning provider rather than other channels. We think really that it has got benefits because we will be able to define, and we should be able to come up with what's the checklist which we want for the provider in the context of self-care. Because self-care we're talking of as not just a parallel system, is just part of the health system. So this should be able to address the method information index plus within the make-up. So we think that this will be able to minimize aspects of distortion of information, but also will be able to inform the users about side effects so that they can be able to prepare for them and be able to know where they can be able to seek for assistance when this arises. But in addition, this was able also to strengthen us on terms of providers, especially the drug shops, especially drug shop operators, to the ability to initiate and follow up on the aspect of self-care. So in a nutshell, definitely we're also able to realign our M&E component because we need to be able to measure so that we can be able to see what's the progress. So the client's confidence, the proficiency in using the various self-care intervention. If they need assistance, where can they be able to access it? And this, we developed it in the 4 thematic areas so that we track the intended and unintended outcomes, the effects of self-care for lessons that will inform decisions. So because all that information will be able to improve on what information will be able to do, how do we program our services?
Great.
And lastly, definitely, it comes with the aspect that it was able to strengthen our aspect of operational research so that we can be able to do the impact assessment of self-care and be able to see what are the things which you need to be able to make. So in a nutshell, it was able to input us and be able to help our guidelines.
Awesome. Thank you, Dr. Olaro. So very important timing-wise, because this research was coming out as you all were developing the guidelines, which is always wonderful for that to see that direct pipeline. And I heard, really thinking about those windows of opportunity related to digital channels, related to drug shops, but also kind of honoring the importance of the touch points with the health system. And in this case, thinking about that for method initiation. And I think we're going to have more to say about the monitoring in a little bit. So thank you, Dr. Olaro. I'll turn now to Hadiza. Hadiza, can you please share a little bit about how stakeholders in Niger received these results? How did they influence discussion about self-care in the country? Over to you.
Merci beaucoup. Bonsoir à tous. Merci à Trinity pour nous avoir invités à ce webinaire. Combien important quand on parle des auto-soins. Et c'est une thématique assez importante parce que quand je prends le cas du Niger, c'est vrai que lorsque l'étude a été mise en œuvre, aujourd'hui, je peux dire que nous sommes dans les discussions pour voir comment comment le gouvernement va utiliser ces résultats pour élaborer des directives par rapport à l'auto-soin. Comment ont été accueillis ces résultats? Je dirais que ces résultats étaient la bienvenue du moment où la couverture sanitaire du Niger est d'environ 50%. Donc, quand on voit que 50% de la population n'a pas accès aux produits de santé, notamment aux produits contraceptifs, cette stratégie d'auto-soin permettra aux femmes et qui, si elles sont initiées et accompagnées, pourront avoir les produits contraceptifs et puis satisfaire leurs besoins. Concernant les directives, je dirais que pour le Niger, des directives spécifiques à l'auto-soin n'existent pas encore, mais nous avons, un pas est déjà franchi, puisque quand on parle d'auto-soin, c'est une forme de délégation de tâches. Une délégation de tâches parce qu'on donne aux femmes la possibilité d'utiliser les produits contraceptifs. Donc déjà, une directive concernant la délégation des tâches jusqu'au niveau communautaire. Les agents de santé communautaire offrent les produits aux femmes, les produits qu'elles peuvent utiliser pour pouvoir s'auto-prendre en charge. Et la perspective aussi, comment renforcer cela, il est question parce que comme
Hadiza?
qui ont, il y a beaucoup de... Oui.
It stopped for just a moment, so maybe the bandwidth is not good. But it's okay. Let's keep going, but maybe you may have to turn off the camera. We'll see.
Voilà, ce que je disais au début, c'est pas évident avec la vidéo. Voilà. Je disais qu'avec les résultats, ce que une partie des résultats que Trinity avait projetés tout à l'heure, il y avait beaucoup qui avaient assimilé les auto-soins à la recherche de soins vers un prestataire de santé. Quand on voit que les femmes ici, dans les résultats concernant le Niger, il y avait qui avaient compris, qui avaient assimilé l'auto-soin à la prise concernant la PF, à l'utilisation des produits contraceptifs. Ça veut dire que quelque part, elles ont la capacité de s'auto-prendre en charge concernant les contraceptifs. Mais un point important, elles ont souligné qu'elles avaient besoin de l'accompagnement d'un prestataire. Donc, pour souligner ici que l'accompagnement du prestataire dès l'initiation jusqu'à l'utilisation et même en cas d'effet secondaire, parce qu'on sait les effets secondaires, c'est assez sérieux, ça constitue une cause de discontinuité de l'utilisation des produits contraceptifs. Ces femmes ont besoin d'être accompagnées par un prestataire de santé. Mais ici, nous avons, dans les discussions du groupe, insisté beaucoup sur la participation et la compréhension des prestataires parce que certains prestataires n'étaient pas pour l'auto-soin. Ils se disaient que mais si ces femmes, on laisse les femmes à s'auto-prendre en charge concernant les contraceptifs, mais nous, qu'est-ce que nous allons faire? Alors, il va falloir ici aussi faire former ces prestataires pour leur faire comprendre que c'est une façon de les aider, c'est-à-dire à les décharger de leur charge de travail parce qu'il y a des fois, ils se plaignent qu'ils sont surchargés. Mais si une partie des femmes comprend ce que c'est que l'auto-prise en charge en matière de planification, on pourra les aider pour les décharger de ce travail. Voilà ce que je peux dire au Niger. C'est une stratégie très importante qui est prise à bras le corps par le gouvernement et qui, dans l'utilisation des résultats de ces recherches, leur permettra de définir spécifiquement des directives à l'endroit des prestataires pour encourager l'auto-soin et accompagner les femmes dans ça pour la satisfaction de leurs besoins en matière de planification familiale. Merci.
Excellent. Thank you, Hadiza. So in the context of Niger, which has not yet developed specific self-care guidelines, these results helped feed into discussions that could inform how those guidelines are developed, what might be contained within them. And I heard a real recognition of the role of task shifting, which is already a policy priority in Niger, and how self-care can be positioned as part of task shifting, in particular, because a lot of people were interested in engaging with community health workers. There are opportunities there. I also really like the last point you were making, which opens more questions, but it is in the case of providers who may be reluctant about self-care, how can you engage them to be more supportive? And so I heard you saying there's an argument of this can help you. You say that you have a lot of work. And so if there are women who are interested and capable, this can help with your general workload, but also presenting it as these results demonstrate that people value provider touch points. And so you all are talking about how to operationalize having contact with the health system along the continuum, whether that's at initiation or resupply or for managing side effects. So we can tell, hopefully we'll hear more about how you all are thinking about operationalizing that. But thank you for that. And now I'd like to turn to hear the perspective from Kenya. A similar question: when you see these results and some of those key takeaways, what does it make you think as you all begin implementing your self-care guidelines? And I'll first turn it over to Dr. Saram, and I'm sure you'll bring in Karen as needed. So over to you, Dr. Saram. And make sure you're unmuted. Right now, I think you're muted.
Thank you very much, Trinity. Yes, thank you very much for this opportunity. And this is Edward Serem from Kenya. And I can see the questions you have posed, of course, is we are in Kenya, we are at a different level. And I can see my colleagues from the other countries are far much ahead. As you know very well that in Kenya, we initiated our self-care agenda a little bit late. And of course, self-care has been recommended by WHO. And of course, we've begun. And we all know the advantages of self-care because it cuts across. As we look at the issues of the healthcare workforce which we have in our country, of course, it is insufficient. It's not. We still don't have the optimum numbers, and we've embraced making sure that we take the agenda of self-care moving forward. Of course, now in our country, we have made some advances, and we are in the process of launching the self-care guidelines and quickly disseminating.
Dr. Saram, we lost you. I'm not here, although it doesn't look like you're muted. Maybe something happened with the microphone. Yeah, we're not hearing you. Maybe while you troubleshoot, we could go over to Karen. And Karen, would you want to jump in?
Is he back? I think he's back.
Let's see, Dr. Saram, I think maybe he's getting headphones. Yeah, it's like maybe the computer shifted the speaker. We're still not hearing you. Let's go to you, Karen, and then we'll see if we can get him for the next question. So Dr. Saram, we're still not hearing you, but we'll go to Karen.
Oh, yeah, please.
Oh, now we hear you. Wait, say again?
You hear me?
Yeah, now we hear you.
Yes. So,
Okay,
so what I was saying is, we are already in the process of launching the self-care guidelines and quickly disseminate them, and thereafter we begin with the healthcare providers training, because of course the healthcare providers have to be acquainted with what has been put in the guidelines, and of course we also have to sensitize the primary healthcare units. Because like now, when you discharge, when now you've discharged a patient on family planning products, and perhaps let's say even hypertensive, then so all these things we are doing at the same time, developing the training curriculum, developing the training manuals, and all those kind of things. Of course, also this one also will follow that. Of course, in Kenya, the self-care agenda is in different fashions. Like now, we are talking about HIV self-testing kits, diabetes self-testing, and now there are other new innovations and creativities on self-sampling for HPV and
We just lost you again, Dr. Sarah. Sorry to interrupt. It's strange. We're not hearing you. Still no. Maybe for the sake of time, if you don't mind, I'll see if Karen wants to add one more thing, and then we'll go to the next question. Karen, is there anything you'd like to add in terms of reactions to those research results?
Thank you very much. I'll add something small. In relation to the results, in Kenya, we do comprehensive counseling because we believe counseling is key, especially in family planning and other areas in terms of reproductive health. So counseling is key because that is where you give information to the client. And then we have healthcare promoters in the community. Once a client is discharged to the community, there's continuity of care and referral system from the community to the facility, and from the facility to the community is now very robust. And also task shifting and sharing, there are some things that the community and the client can do for themselves in the community after they have been given information from the facility. And we have facility phones where a client can be able to call the facility for more information in case they need help, or if they need to come back to the facility, they are always advised to come back to the facility. And then training of pharmacists, because of the MPA-SC, pharmacists have been trained and they are supposed to have counseling rooms in the pharmacy so that when a client comes for self-care, they do counseling, offer services, and then refer them appropriately. Then data quality. Elements like DMPA-AC is already included in our primary registers where it is tracked whether client was injected by the healthcare provider or they were taught the skills on how to be able to inject themselves. And also development of IEC materials in terms of family planning. They are on course, they were done. They are just waiting to be disseminated to the healthcare providers because of self-care. And then the RH research agenda came in handy. We have developed research agenda for RH, and self-care is top on the gear in the counties. So counties have formed teams to be able to do operational research in terms of self-care, so that now we can be able to track and see which impact that we can make in the country in terms of self-care beside other RH research agendas. I think that is what I can add.
Awesome.
In what Dr. Serem has given to us. Thank you.
Thank you so much, Karen. So again, hearing some similar themes about how to situate self-care in relation to task sharing, windows of opportunities through drug shops. But I really also want to pick up on what both you and Dr. Olaro said, which is, this is in some ways, this is an old thing, self-care, but it's also a newer thing in terms of how we're operationalizing it. And so being able to do implementation research to help continue to answer questions and make adjustments is a priority. I think that's something we don't want to lose track of. Okay, I'm going to ask if we can launch our next two poll questions, so one after the other. So the question number 3 is going to pop up. I'm just curious to get a sense from our participants about this question. Does your country have standalone self-care guidelines? So guidelines that are for self-care. Yes, no, or you're not sure. Let's see, among our participants, how many countries have self-care guidelines? Okay, let's take a look at the results. 27% yes, 45% no, 27% not sure. So equal parts yes and not sure, but the majority, not quite the majority, at least about half, do not have standalone guidelines. Okay, so now the next poll question, from your own opinion, do you think your country should have standalone self-care guidelines, or that a country should have them? Yes, no, or not sure. So this is your personal opinion. All right, let's see what you all think. Overwhelmingly, you all think that they should have self-care guidelines. Very interesting. Thank you for doing that, because in fact, the next question that I want to pose to each of our speakers is related to self-care guidelines and whether or not a country should develop them as separate self-care guidelines or not. We wanted to kind of create a safe space to talk through what may have been the deliberations among stakeholders about whether or not to develop those guidelines. Again, for Kenya and Uganda, we have two countries that have decided to do that. And so I think for you all, the question is, what made you decide to pursue them? Really, what was the value that you all saw in developing self-care guidelines? For Niger, where they have not yet, I think we'll be asking what would help stakeholders to decide, and what questions do stakeholders have. So let me first I'll go back to Dr. Olaro and ask you very briefly to just share a little bit about why you all decided to pursue separate self-care guidelines. What were some of the top reasons or the top values, perceived value of doing that? So Dr. Olaro, over to you.
Okay, thank you once again, Trinity. The self-care guideline, first of all, should not be separated by domain of health, but rather a comprehensive covering all major aspects of health, including sexual and reproductive health, mental health, and NCDs, among others. Actually, for Uganda, we had originally developed sexual reproductive health specific guidelines based on the guidance from WHO. But when we took them for approval, through the structures of the ministry, we had to answer a lot of questions as why we are living NCDs, why we're living mental health. And so we had to get back the go back the drawing line. Now, actually, we plan to revise this to include mental health, because even in the sexual and reproductive health space, there's an aspect of mental health. There's an aspect of NCDs. So all these are important aspects of health across the individual life course. So remember that self-care has been practiced already, especially in the space of palliative care, in the area of diabetes. So the guideline will ultimately have a wider range of domains. We are cognizant that it definitely should not be able to blur the sexual and reproductive health thinking, but we're looking at that, we're leveraging, actually the other parts are leveraging on sexual. So the number of domains, we think that definitely it should be having a multi-sectoral approach with all key players in the sexual and reproductive health space, including academia, under the stewardship of the ministry. So the purpose of the guideline is to guide the introduction of and scale up sexual and reproductive health care in Uganda. We already developed, working with the Department of Health Promotion and Education, develop key messages on aspect of antenatal, aspect of STIs, aspect of family planning, aspect of post-abortion care. So our vision is to accelerate progress towards universal health coverage by integrating self-care into existing health systems. That's one of the strategies. And we think that integrating has got benefits, because we might not have resources alone to run sexual and reproductive health, but the resources we have already, like in the self-testing for HIV, We already have resources from Global Fund, so we think we can be able to do it. Aspect of self-testing or self-sampling, like for human papilloma virus, those are things which already we think we should be able to do. We should be able to find out. So with the guidance of WHO, we think that we should be able to consolidate self-care interventions and benchmarking self-care definitions and components of self-awareness, self-testing, and self-management. We have had an inaugural stakeholder engagement for buy-in. In the month of July, we actually had a self-awareness month, and we had even commemorations. We have a self-expert group with experts from academia, local government, civil society organizations, and one of them specifically is do advocacy. Academia is do aspect of monitoring and learning, and then the other aspects will be able to work on aspect of implementations. Like we have colleagues on call from Mukono. When we developed our guidelines, we actually had to test them in the context so that we see what is applicable. Are there some things we need to change? So onboarding of the national guide consultants to coordinate the self-care guideline, drafting the self-care guidelines. So all this we've been doing them wholesomely, covering all the aspects of antenatal, family planning, STIs, and post-abortion care. And we think that we have established teams to do advocacy, supply chain, and finance. Some tips to the expert group. So actually, we've got so many experts now in self-care, and we are now actually got into the buy-in as the ministry, because we are looking. That's why we saw that if we expanded it to include mental health, and the buy-in actually improves even much better. So the other aspect definitely is, I said we had to test the guidelines at the district level, and adaptation and framework. So we are looking at, because our care definitely is truncated into levels. So we want to see what can be done at community, what can be done at health center 3, what can be done at health center 4, so that we have good kind of standard of self-care at those levels. So the last thing definitely we're going to do is to update the guidelines. So for Uganda, instead of a standalone guidelines, we're actually going to have a guideline which is integrated among those aspects. I don't know whether I should be able to stop there.
Yes, that would be great. Just so we can make sure that we have time for others. But I think you helpfully demonstrated the interest that you all had in pursuing guidelines, but recognized that these necessarily require connection to other existing guidelines and protocols. So there's a lot of coordination involved.
We are not hearing you.
Dr. Saram? So I think there's a lot of coordination that's involved, which can make the process complicated, but it sounds like you all are well underway. Let me pass it now over to Hadiza to kind of get a different perspective. So again, Niger has not yet developed guidelines. So I think the question is, are stakeholders considering developing the guidelines? And what are the questions that they're asking to help decide if they should do this? What are some of the considerations? So over to you, Hadiza.
Merci beaucoup, Trinity. C'est vrai, on l'a dit, le Niger n'a pas de ligne directrice spécifique concernant les autosoins. Mais les autosoins, comme je l'ai dit tantôt, qui est une sorte de délégation de tâches et de l'agent de santé à la personne même qui va bénéficier des produits contraceptifs, on donne la possibilité à cette personne d'utiliser elle-même les produits contraceptifs. Il y a une directrice spécifique concernant cette délégation de tâches. Et c'est à partir de cette ligne directrice, justement, un partenaire de mise en œuvre de la planification familiale au Niger a fait un pilote dans une des 8 régions du pays concernant l'utilisation du DMPA sous-cutané par les femmes en milieu communautaire. Ça s'était passé dans 2 ou 3 districts, je ne maîtrise pas, je sais qu'il y a eu ce pilote-là. Et sur la cohorte de toutes ces femmes-là qui ont été suivies, et ces femmes étaient capables de s'auto-injecter le Sayanapress, donc le DMPA sous-cutané, et elles ont été, bien sûr, je l'ai dit, l'importante place du prestataire de santé depuis l'initiation jusqu'à l'accompagnement et puis jusqu'à la visite-retour de la personne bénéficiaire. Les prestataires avaient accompagné ces femmes et ces femmes, quand elles avaient présenté des effets secondaires, elles savaient comment prendre en charge ces effets secondaires. Il y en a qui étaient restés et se faire prendre en charge chez elles-mêmes, d'autres ont fait appel aux prestataires de santé. Donc, c'est un pilote dont les résultats ont été beaucoup appréciés par les parties prenantes. Et de là, toutes ces parties prenantes avaient beaucoup discuté sur l'utilisation donc de ces auto-soins, la promotion des auto-soins. Est-ce qu'il fallait faire, en dehors de cette directive de délégation de tâches, écrire des directives spécifiques aux auto-soins? Pour le moment, nous sommes en train de... Les résultats sont sortis seulement il y a quelques mois. Des recommandations ont été élaborées et de ces recommandations, il est ressorti quand même ce sont des résultats encourageants, mais c'est de faire d'abord de faire savoir à la communauté, à toutes ces femmes et à tous ces hommes-là qui désirent faire l'autoprise en charge, ce que c'est que l'autoprise en charge, parce que ce n'est pas tout le monde qui comprend, et qu'on leur dise qu'il y a cette possibilité, les produits sont disponibles, et nous pensons que de là, le ministère, quand même, du moment où c'est une stratégie qui lui tient à cœur et qu'il est totalement engagé, il va aller vers l'écriture de cette directive et pourquoi pas, au fur et à mesure, intégrer les autres thématiques de la santé sexuelle et reproductive. Et même si, par ailleurs, ici, nous faisons de la PF, la planification familiale, une stratégie très porteuse. C'est pourquoi même il y a une direction spécifique pour la planification familiale. Avant, c'était dans la direction de la santé de la mère et de l'enfant. Mais maintenant que la planification familiale est à part, nous pensons que le gouvernement va aller vers l'écriture de cette directive puisque le groupe technique de travail, à travers son président, qui est le directeur de la planification familiale, disait que l'auto-soin est une stratégie qui va accompagner les femmes dans la satisfaction des besoins non satisfaits. Donc, je pense que le pays va aller dans cette perspective dans un premier temps, quitte à ajouter les autres thématiques de la SR.
Okay.
Oui.
Thank you so much, Hadiza. It's so interesting to hear a different perspective. So in the case of Niger, it's kind of in a progressive mode. So taking things step by step, there's already a policy that allows for self-injection. It sounds like people are very interested in continuing to see how that unfolds. There have been encouraging results, and really focusing in some ways first on the demand side. So making sure that individuals know how they can engage in self-care. And then as that progresses, the country may decide to develop separate self-care guidelines, but perhaps that would be more inclusive, as we heard is the case in Uganda, not just family planning, but building on the strong experience of family planning to include other health areas. So very interesting. I'm mindful of time. So what I'd like to do now is check and see if Dr. Saram's audio is working. And if not, maybe I'll ask you, Karen. Oh, Dr. Saram, can you hear us?
Yes, can you hear me?
Yes, we can. So, Dr. Saram, if you would please, in just a few minutes, provide your perspective on kind of the why behind developing self-care guidelines in Kenya. What did you all see as the real impetus or value of developing those guidelines?
Well, I think there was a question which we had posed that was their value, yes or no? I'll give it 50-50.
Yeah.
And yes, yes, there is a lot of value because I mean, as we in the I mean the self I mean the standalone. I mean, I think the issue is the value of self-care alone and not comprehensive. Well, this is something which is, of course, it is something which is new, and as you introduce something new, or you really have to be a little bit more cautious because most of the healthcare workers will take it in bits, and therefore coming up with a self-care for reproductive health, mental health, diabetes, hypertension, and all the others might be too much to be taken by the healthcare workers. And so in my view, of course, coming up with, selective, like now when we talk about reproductive health, of course, when you talk about reproductive health, not only on family planning, but also on issues of maternal health, then you keep on cascading because at the end of the day, we will also want to do some form of reporting because we would like to get a lot of data as to how is it being taken in, and of course on issues of the end products, the wastage, how is it being managed, and at the same time, as we develop the self-care for healthcare providers, of course, we are looking at coming up with other guidelines for the patients. So, so going by this, therefore, is if we load the system too much, then it might be overwhelmed because we are looking at perfecting the implementation of self-care. So in a way, if you do it wholesomely at once, then maybe it might create some confusion. But that's my view. Maybe Karen could be having different views on how she's come. Maybe I can give her so that she can contribute on that.
Sure. Please, Karen, over to you if you'd like to share more on the value of developing the guidelines.
Thank you very much. I want to concur with Dr. Serem that in Kenya we had a reason why we started, and of course with reproductive health. And in Kenya, we believe that reproductive health is the mother of the others. We lead and others follow, of course, in terms of now self-care. Although self-care was there initially in all aspects of health, it's just that it is not documented as a guideline. But now that we started off with reproductive health, and we made sure that in reproductive health self-care guidelines, we included all maternal and newborn health. We did post-abortal complications. We did FP and contraceptives. We handled infertility. We handled cross-cutting issues like STIs, disorders in sexuality, SGBV, RH, cancers in RH, non-communicable diseases. We also did referrals. We also handled mental health and reproductive health. So we wholesomely did reproductive health area, and then some of the other areas we can now advise on how to be able to develop other guidelines related to health in terms of self-care. But when we are giving information to the healthcare providers, we give them information wholesomely so that during cascading the RH self-care to the community, they wholesomely integrate services. Thank you.
Thank you, Karen, and thank you, Dr. Saram. So again, I think you're really highlighting the element of multi-sectorality, coordination that seems inherent in developing and implementing self-care guidelines, but also I'm loving, as somebody who works in family planning and reproductive health, I'm loving the the enthusiasm for the pioneers that, you know, FP and RH often are in this field. So thank you so much. I would like now to open it up to our participants to ask questions directly to our speakers. So again, this is a safe space, a happy table, a place for you to ask the question that you've really been simmering on to these experts who are in the midst of thinking about and doing and implementing self-care. So if you have a question, I would like to ask you to please raise your hand so that I can call on you, and then you can come off mute. And the way to do that is at your toolbar on the bottom. You may see something that says reactions, or you may need to click on the 3 dots, and then you click on reactions, and then you have an option to raise your hand. So if you can do that to raise your hand, I will call on you and you can ask your question. You can also put them into the chat if you would like to. And so I will go ahead and ask a question that has already been put into the chat from Patrice. And Patrice asked, is there a difference between community-based distribution of contraceptives and self-care? Is there a difference? So maybe I'll just ask if any of our speakers would like to respond to that. Do you see a difference between community-based distribution of contraceptives by community health workers and self-care? Dr. Olaro, Dr. Saram, Hadiza, would one of you like to respond?
Okay, thank you for the questions. I think as you had the definition from of self-care is the individual, families, communities responding on how they prevent, first of all, promote, prevent, and then maintain health, but also cope with the disease or cope with illness. So community distribution is not just self-care, but is one of the pathways of which we can be able to deliver self-care, because the women can actually access the injectables from the community workers, but they are the ones who administer the self-injections themselves. So it's kind of like what is, so it's not like the other way around that. So it's just one of the pathways. So we really would want community.
Yeah.
And we think that since women live in communities, I've always said like this. In my community, women can walk to the facility when they still have a young child. I mean, to the facility. When they don't have a child, they have no reason to tell the man, the husband, why they are going to the health facility. So if we have community health workers, this can be a good way where women can be easily access family planning commodities within the community.
Mm-hmm. Excellent. Thank you, Dr. Olaro. So it is one part of it, but not the full picture. Dr. Saram, did you want to respond?
Yes, I wanted to respond on this. Community-based distribution is not, in my view, is not the same as self-care. But community-based distribution gives pathway to self-care, because by the time that person is distributing the products, the woman or the client already knows what she wants, or he or she wants. So I think CBD just aids self-care. Thank you.
Mm-hmm. Thank you. Great. Okay. I'm not seeing any raised hands. Maybe it's hard to see how to do that. So again, you can click at the bottom of your screen on reactions and raise your hand, or you could type a question into the chat. I'd love for questions to come from the audience. I do have some more questions I could pose, but I'd love for you all to ask questions to our speakers. So any questions from the audience? Okay, let's see. I'm looking in the chat. Okay, it's a comment about self-care perhaps being a useful strategy for people living with disabilities of various sorts, because it can also perhaps avoid or protect against some stigma and discrimination that they might encounter in the health system. That was a comment from Judone. I wonder if any of our speakers would like to react to that. I wonder in Uganda or in Kenya, if within your current guidelines, is there any portion that addresses people living with disabilities?
First of all, our guidelines are inclusive, because the other aspect which we didn't speak about is that we also run we have the equity committee of which is the aspect of self-care. So we're looking at who are those different groups which are being left behind. So we are looking at all those ones, the young, the old, probably those who are in the remote rural areas, and those with disabilities. So we're all looking at what are the methods where they can be able to reach. So if you looked at even our self-expert group, we actually have a person who is living with a disability as a member of our expert group. So we are as inclusive as that.
Great, thank you, Dr. Olaro. I wonder, it makes me think about another question that I had, but I see Dr. Saram, you came off mute, go ahead.
Oh yes, on the same question, of course, the self-care guidelines, of course, addresses issues on the people with disabilities, because those are the population which are actually dependent, and they depend on other persons to provide care and all the other things. And also this also addresses on issues of palliative care and the hate. So the self-care, as of course, has not left people with disabilities.
Great. It was making me think about this question of equity as well. And so I think when there's discussion and dialogue around self-care, we sometimes hear what I might call competing messages or things that are in tension. On the one hand, self-care is often presented as a strategy to address kind of under-resourced health systems. If there's, overworked providers, then self-care might be an important strategy. On the other hand, people have flipped that and said, is that just maybe an excuse to kind of ignore some of those harder to reach populations by saying, well, we'll let you have self-care, and therefore we don't need to kind of address some of our access issues. When I think about the research results that I shared, people really want that touch point with the health system. So I wonder how you all are thinking about that tension. Yes, this could help in resource-constrained environments, but people still have a right to access, providers and health system, and have that be a quality interaction. If maybe somebody would like to respond to that, please go ahead. Maybe Hadiza, I don't know if you would like to jump in on that question.
Oui, en fait, quand il y a eu cette question concernant les personnes handicapées, justement, ça m'a fait penser tout de suite à l'équité. Et ça fait partie de nos indicateurs parce que nous avons nos indicateurs d'équité ici au Niger, dont nous discutons l'analyse avec les membres du groupe technique de travail sur l'équité. Et justement, quelle était la relation qu'on pouvait faire entre l'auto-soin et puis l'équité. C'est vrai que ces personnes handicapées, pour l'auto-soin, ça leur permettra de diminuer la marginalisation envers ces personnes-là. C'est parce que c'est discret, c'est confidentiel. Et maintenant, l'accès aux produits contraceptifs et au-delà à certains produits leur sera très bénéfique. Maintenant, la question de Trinity concernant ce groupe de personnes vulnérables. Et vous avez dit quel était comment accéder.
It's okay, Hadiza. I was you already responded a little bit about how can countries still implement self-care policies and programs while ensuring that that doesn't lead to more marginalization. I think that's really the question.
Yes.
And so anybody want to say anything more about that interplay between self-care and equity? I think what's important to note is that across our countries, it sounds like those linkages are being made specifically, both in terms of language in the self-care guidelines, but also some working groups that are focused on equity and are having discussion with self-care working groups, or in the case of Niger, the working group is one and the same. And we can share some more information also about equity within family planning, reproductive health. There's a global working group that R4S is supporting, and that is linked to these discussions around self-care. I'm seeing some questions in the chat related to training and sensitization. So there's a question specifically for Kenya, although I think it could be for the other countries as well, about how to integrate self-care into training curricula, in particular if there's already some hesitance on the part of providers. What are the strategies for including self-care in training curricula? And a question about how to train women or sensitize women around that. I think maybe Dr. Saram, Charles, Dr. Olaro, did you want to jump in?
Okay, so thank you for the question. I think when we look at for the aspect of sustainability and that you have the health workers come out of the institutions when they are knowledgeable on self-care, I think that's key, and we're moving towards that direction. At the Ministry of Health, already all our new policies which are coming and guidelines which are coming are already integrated. If you look at our commitments, the FP 2030 commitments, if you look at our costed implementation plan for family planning, our advocacy strategy, all those ones, family planning is a component in it. So the next thing definitely, when there is opportunity, when curricula, because you can't just take it to institutions, it's only when their curricula is being revised, then when the opportunity comes, then you're able to see how self-care can get integrated. But I wanted to make a comment on the question which you said that how do you do the balance of the two? That we think that self-care, we are now saying people with disabilities take care of yourself. I think no. I think self-care remains as part of and parcel of the health system. So it's not a standalone. That's why we have to continue to monitor quality, because the products which are coming out either for self-testing, we have to be able that they are validated by the system so that they're just not thrown out into the world. So we'll continue working in that. And also when we have the M&E aspect plus the learning aspect, then we're able to see which groups are being left behind so that we can be able to put some actions to be able to address the marginalization of these groups. So, and as I did indicate, from the planning aspect, we have included a person with a disability. We have included the Ministry of Gender, Labor, and Social Development, which actually handles issues of social protection. So they are part of it. Ministry of Local Government, where actually most of the implementation of the activities are taking place. Ministry of Education, I think, to handle issues which you have just raised. They are all part of our expert group.
Excellent. Thank you, Dr. Olaro. And such an important point on also using your monitoring data to continue to assess who may be reached or not reached by some of these services and opportunities. I wonder, Dr. Saram or Karen, if you'd like to speak to how training is unfolding in Kenya.
Oh, yes. Thank you. Thank you very much. Training, of course, once in Kenya, once the guidelines have been approved by the national government, it automatically taken over by the training institutions, because that is one of the sustainability measures, making sure that the new employees who are going into the market are already trained on the same. So that is part. That is what we always do in Kenya. The other thing which I also wanted to respond, I think you had posed a question as to, the issue of self-care. Will it therefore compromise the quality? The quality of care, or pushing the patients to stay at home. But I think the guidelines are very clear. Our guidelines are very clear that if a healthcare provider has been trained on that, then they have to engage and consult the patient, as Karen has mentioned. That within a period of time, they have to come back to the healthcare facility for further instructions and further maybe testings and review if the drugs are working and all those kind of things. So in one way or the other, it is as the self-care agenda actually sorts out the issue of human resource deficiency, but in a way it doesn't really in a way is not aimed at losing the quality of care to the patient, because at the end of the day, if like
I think we may have lost Dr. Saram again. Karen, did you want to add anything to that related to the provider training?
Yeah, the provider already in Kenya, we have trained a number of, we have pre-tested the materials, because we developed training after we did the guidelines. We developed training packages for healthcare providers, all the clinicians, including nurses. And then after we have done that, we are hoping to develop community and also IEC materials for the community, so that it is developed in a simpler language. But in Kenya, when it comes to family planning commodities, it is issued free in the health facilities. And then it is given in a way that a client is purposefully return back after some time, and then they are educated when to seek help. And then there's continuity of care in the community using the community health providers that already are working in our communities. And then the follow-up is very robust in Kenya when it comes to now community units where the community healthcare providers are working. And then the surveillance when it comes to side effects, the client can report back and even call the providers, because facilities have emergency numbers where a client can be able to call a provider for information. And then there's that health education in our facilities. Every morning when you go to maternal childcare, every morning before they start services, they do health education to our women in terms of self-care, so that after the services, they can be able to ask questions where they feel that they need help. And then in case of the things they need to buy for self-care, for continuity of care at home, they are advised which kind of model they can buy and where they can be able to buy them for continuity of care at home. But that doesn't mean that they have to stay at home. There is a referral system where they can be able to come back or even call the facility for help where need be. Thank you.
Thank you, Karen. It's raising another interesting issue for me, and we haven't really used this word yet today, but the word is choice, and kind of honoring and making space for women's choices. We obviously talk about that when we talk about informed counseling and informed choice of a method. I think it relates as well to the conversation around self-care. Does a woman want to choose a method which she can then use on her own or with a bit more, let's say, time and space between provider visits? You know, if she's using oral contraceptives, can she walk away with 6 months or 12 months? Can she learn to self-inject? And so the balance between maybe if that's what she chooses, how do we not insist that she come back at a certain point if she doesn't need to? But then there's the choice of women who want to keep coming back and seeing the provider. So it's kind of a continuation of that conversation around choice and how do we allow for the range of choices. And some people will choose self-care and will choose to have less contact, but would still like to be able to contact when necessary. It's very interesting. But you also mentioned something, Karen, that I'd like to take and then hand to Hadiza in our last few minutes, which was communicating to the community, to individuals in simpler terms about self-care. And Hadiza, I know that in Niger, that's part of the discussion, and the priority is focusing on community level communication and sensitization about self-care. I wonder if you could share with us how you're doing that. What are even the terms that you all are using? Are you talking about self-care, or are you explaining it differently as those IEC or communication activities unfold at the community level?
Merci Trinity. Explication au niveau communautaire. Nous avons effectivement dit pour la communication, c'est important que la communauté bénéficiaire sache ce que c'est même l'auto-soin. Utiliser le terme d'auto-soin, ça n'existe pas dans les langues ici parlées, mais c'est d'expliquer le concept. Comment nous allons expliquer le concept? On a appelé ça contextualiser la définition de l'auto-prise en charge en matière de PF, c'est-à-dire organiser ce qu'on appelle des assises communautaires. Donc, on va dans un village, on convie toutes les femmes, on convie tous les hommes autour, bien sûr, des leaders, notamment les chefs de village, et on leur explique c'est quoi l'auto-soin. C'est quoi l'auto-soin, qui peut être bénéficiaire si la personne désire, comment procéder pour cela, quel contact elle aura avec les services de santé, quel accompagnement elle aura. C'est comme ça qu'on éduque la communauté pour qu'elle comprenne ce que c'est l'auto-soin. Justement, pour avoir l'engagement, là, toutes celles qui sont intéressées, tous ceux qui sont intéressés, vont pouvoir dire, ah, dans ce cas, j'ai la possibilité de le faire, je sais où aller, en cas d'effet secondaire, je sais à qui m'adresser. Et on présente en même temps les produits qui sont susceptibles d'être auto-pris, parce que ce n'est pas tous les produits contraceptifs qui peuvent faire l'objet d'auto-soin. C'est comme ça qu'on fait dans la communauté. Tout à l'heure, le Gwenda avait parlé de la formation des prestataires. C'est important aussi de les former d'abord eux. De former d'abord eux parce que c'est eux qui vont utiliser leurs communicateurs pour aller dans la communauté et puis expliquer aux gens en même temps avec les prestataires ce que c'est l'auto-soin, qui peut le faire et comment le faire. Voilà comment on fait au Niger.
Thank you, Hadiza. And I really appreciate that, the fact that, you know, the term self-care doesn't exist in some of the languages spoken, but instead you all are explaining the concept. So we've nearly reached time. I just want to thank all of our wonderful speakers today for sharing your experiences and your thoughts and perspectives. Thank you also to our audience and for the questions that you asked. I have one last poll question for you all before we go. It's just a little bit of fun. But this question is, we're talking a lot today and recently about self-care for family planning and reproductive health. Do you think we will be talking about self-care for family planning and reproductive health 10 years from now? Will we still be talking about it? The answers are definitely yes, maybe, or no, we will have moved on to something else. So just for fun, do you think we'll still be talking about self-care in 10 years? All right, let's see what you think. Will it still be a hot topic in 10 years? Most of you think yes. Excellent. About 28% maybe and 17% no. So thank you for looking into the future. And thank you for being with us today to talk about self-care for family planning. I put some links into the chat for more resources related to the research that R4S conducted. I would definitely encourage you to check those out if you'd like to learn more about that. And you'll also see there's a survey for feedback on the session. But once again, I'd just like to thank you all and thank you to our speakers and wishing you a good rest of your day and also a good rest of your work in promoting and supporting self-care. So thank you all. Bye-bye.
Thank you.
Thank you, and bye,
Merci.
everyone.
Thank you.
Merci. Bye.
Thank
Thank
you.
you.